Hi, this is our presentation on tuberculosis. And we're just going to get started with an introduction about ourselves. So to start off, my name is Yexalen. My major is chemistry with an emphasis in biology. And a fun fact about me is that my name means star of the sea.
Hello, my name is Brooklyn. I'm an anthropology major with a minor in integrative biology. I'm going to be a senior in this coming fall. And for my fun fact, I did a 3-month archaeology field school in Southern Utah.
Hi, I'm Sidnee. I'm going to be a junior this coming year. My major is international studies with the pre-med track. And a fun fact about me is I've had a mysterious illness in Peru.
Hello, my name is Alice. I'll be a senior in the fall, and I'm majoring in biochemistry and international studies. Fun fact about me is I'm minoring in Chinese, and I've studied abroad in China for 2 summers.
Okay, so we're going to start off with some quick introduction to the disease. So tuberculosis is a bacterial infection caused by a group of phylogenetically close bacteria, collectively known as the Mycobacterium tuberculosis complex. So in humans, TB is primarily caused by Mycobacterium tuberculosis or Mycobacterium africanum, which is a variant that's limited mainly to West Africa. The pathogen was discovered in 1882, so it's been around for a long time, by Robert Koch. And by 1909, it was well understood that those who came into contact with TB patients were susceptible to developing symptoms. William Osser stated that all who mix with tuberculosis patients got infected, but remained well so long as they took care of themselves and kept the soil in a condition unfavorable for the growth of the seed. That is just kind of like an introduction to what we're going to talk about later, just to show, like, for our experimental design, we'll expand on that a little bit later. So the bacteria works by binding to varying host receptors. The receptor used to enter the host has effect on the immune response in humans. So for an example, one receptor may cause an active reaction of oxygen intermediates, and another could prevent the activation of respiratory burst. So the bacteria is able to affect the host in a lot of different ways, depending on where or how it binds within our cells. The bacteria is estimated to have evolved over 150 million years ago, so it's been around for a long time. In humans, TB dates back to around 10,000 years ago, which suggests a really long history of coevolution between humans and TB, but research on the emergence of this is still taking place and being debated. It's a really unique disease, though, because currently we don't know of any animal reservoir of TB that it spilled over from. So the disease is only transmitted from human to human airborne transmission. So a lot of other animals and mammals are susceptible to different strains of TB, especially non-human primates like rhesus macaques and pigtail macaques. And in captivity right now, the rates of transmission between these animals are going up as much as 30%, which makes it considered to be an emerging disease in wildlife. This, for as much as we know, has come from humans. So the transmission could provide an opportunity for TB to further mutate, maybe become more virulent and affect other populations as much as it affects us. There's also a lot of new selection affecting the evolution of TB. For most of human history, the most important selective pressures acting on the TB pathogen were the human immune system and change in human demography. But up until recently, those were the main factors. And now there are new selective pressures like the HIV virus and the use of anti-TB drugs that are affecting the virulence levels, transmission, and fitness of the bacterium. So it leads us to question, how are these new pressures going to influence the relationship between humans and TB? Because this is such an ancient relationship that we can't really predict how it's going to change off of these new variants.
Just as Brooklyn kind of mentioned briefly, TB is transmitted via indirect transmission, which is mainly through respiratory droplets. So if someone coughs, then the bacterium is transported by those cough droplets. In terms of environmental persistence, it's been recorded that Mycobacterium tuberculosis can persist in a laboratory setting for up to 12 months. Now, of course, more research needs to be done to determine how disturbing this bacterium will affect its environmental persistence and its application to the real world. In terms of symptoms, just to expand on what Brooklyn said, the bacterium can bind to different things within the body, and these different bindings can determine the symptoms that are shown in a patient. There are many different types of tuberculosis, the main one being usually pulmonary tuberculosis, which will cause a nasty cough, chest pain, night sweats, fever, weight loss, and And that is the one that is mostly seen with tuberculosis. However, extrapulmonary tuberculosis, the tuberculosis that is seen outside of the lung organ, known as skeletal or liver, can also be manifested. Two of the most popular or common is tuberculosis lymphadenitis and genitourinary tuberculosis. Tuberculosis lymphadenitis leads to enlarged nodes in regards to tuberculosis, and genitourinary tuberculosis is tuberculosis that affects the reproductive system and urinary tract system for both men and women. And in terms of treatment, antibiotics is the most common, but just as we said, tuberculosis can manifest itself in different ways throughout the body. So a huge argument right now is that okay to have the same treatment regimen for different diseases? And a lot of the ways that treatments differ is by their duration. For example, pulmonary tuberculosis is treated for 6 months on prescription antibiotics, whereas extrapulmonary, such as liver, could be treated for 9 to 12 months. So it is quite different to have antibiotic treatment. And in addition, the common prescription of antibiotics will lead to things such as antibiotic resistance that, like Alice will talk about later. Surgery is also a common treatment, such as chemotherapy for some extrapulmonary tuberculosis. And in terms of prevention, there is a vaccine available. However, the vaccine does not prevent reactivation of latent pulmonary infection. And as of 2019, there were 15 new candidate vaccines for TB that were under investigation.
One of the main factors that has led to the evolution of TB is actually human caused through selective pressures caused by antibiotics, as Sidney mentioned. So multi-drug resistance has become ever increasingly prominent in our world today, with an alarmingly increasing rate of 20% annually. And part of this could be due to increased testing and detection systems, but a lot of this is just simply due to physician error and patient noncompliance. So by not taking the full length of antibiotics, this allows the most resistant strains to then infect the entire community. So this quote here sums it up pretty well. No educated doctor will knowingly apply a single drug to treat TB, but monotherapy of TB still occurs. So a major reason maybe why monotherapy occurs is simply because the prevalence of MDR-TB is 99% of those cases are in low-income countries. So this is a huge burden, with only 20% of these patients having access to proper treatment. Treatment typically takes 6 months and can cost anywhere from $85,000 to $120,000. So this has led different physicians and scientists to try to come up with solutions to MDR-TB, and one that has been quite successful in a case study in India found with 72.4% of successful treatment for patients, and this was DOTS, or directly observed treatment, short course. So they would just provide medication or these antibiotics to patients and then directly monitor them to ensure that they were sticking to this very strict regimen of treatment. Another way that TB has evolved and has the potential to evolve in the future is through spillover. So as Brooklyn mentioned, TB is primarily in humans, but there are different strains that are also present in different mammals. So one is Mycobacterium bovis, which is found in cows. So cases from these cows have been found in so many different mammals, from sheep and goats to cats, rabbits, otters even. So depending on the area, different species have been found to be maintenance hosts, spillover hosts, or both. So this just presents a huge area for this bacteria to develop. And M. bovis has actually been found to infect humans. It's not as common anymore, but it was caused by drinking unpasteurized milk. So with fully cooking raw meat and wearing proper PPE when dealing with infected animals, as well as pasteurization, we have significantly decreased this infection caused by M. bovis, but it still occurs in some underdeveloped countries.
Okay, and environmental factors, affect the prevalence of tuberculosis. So to just name a couple, we have like air pollutants. So aside from pollution, depending on the geographic area, some fires might need to be kept on for hours long with poor ventilation, and that increases your daily exposure to smoke. HIV, we know, compromises the immune system and progresses the disease. And then there was also a study found that tuberculosis is more prevalent in correctional facilities. So as we can see, there was an average incidence of latent tuberculosis in prisons was 26.4 times higher than in the general population. And just for TB, that rate was 23.0. And then there's some other factors you can read about concerning the difference between like high income countries and low income countries. And then there's some ecological factors. So xenobiotics such as cigarette smoke and air pollutants worsen TB by disrupting the intercellular pro-oxidant antioxidant balance. And that disturbance of the redox homeostasis furthers the establishment of infection. Is not only bacteria being affected, but the host's immune system is infected as well through diabetes, malnutrition, indoor air, and so forth. And then some other factors are genetic susceptibility. There's some host genetic factors that can make someone more susceptible or resistant to TB. Vitamin D deficiency. It's possible that the metabolic vitamin D could enhance macrophages to better phagocytize MTB, and socioeconomic disparities, as mentioned before. So access to healthcare, there can be cultural barriers such as language or different healthcare systems.
Moving along to our experiment, we noticed that there have been recent studies done in 2020 that correlated depression and anxiety in tuberculosis patients. So we thought this is an area of emerging research where we could propose an experiment. So this particular study found a correlation between depression and anxiety in TB patients, and it was done in Southwest Ethiopia at a public health facility. And so a high prevalence, 55.9% of patients had depression and 54.6% experienced anxiety, and depression was associated with these factors, particularly perceived stigma and high perceived stress, both with depression and anxiety.
There's also another study that found the association between tuberculosis and depression and negative TB outcome on their treatment. So out of an odd ratio of 7.79, it landed at about 4.26. So a fair strength of prevalence, and this can be increase higher rates of treatment failure, can also increase development of antimicrobial resistance, as Alice mentioned before, and as we know, depression reduces your immune system.
So due to this confirmed correlation between stress and active pulmonary tuberculosis, we have established that we think that an establishment of stress management programs will ultimately decrease the symptoms caused by tuberculosis.
So our experiment will compose two groups, mainly 25 in each group, a control group that will be treated with antibiotics and a variable group that will have antibiotics plus a stress management. The location will be as with the other study in Southwest Ethiopia. There'll be no preference on gender. The age will be 25 to 45, as this is the age most prevalent for tuberculosis incidence. The stress management will be individual 1-hour therapy visits with a licensed therapist for once a week for 6 months, which is, as I said, the normal duration for the treatment of pulmonary tuberculosis. And with the initiation of this study, we will propose a survey. This will also determine their applicability to the study. Between 3 months between each survey, having 3 surveys total, testing the participants' stress, how their stress changed, how the stress could affect the tuberculosis, and after the stress management implications, how the tuberculosis changed as a result of their changed stress.
So based off of the other experiments that we have looked at, looking at stress and the correlation between that and TB, as well as reviews of a multitude of tests studying this, we think that most researchers, and we think that we too will come to the conclusion that patients who are being treated for TB are more likely to develop psychological disorders like anxiety, PTSD, and depression. So those in the control group who are not given access to the therapy that other in the experimental group are given access to, those individuals could develop increase in symptoms relating to stress-related diseases like anxiety and depression. And then those in the experimental group will decrease the severity of TB symptoms, and the effectiveness of their treatment will increase. So they will get healthier faster. And also if anyone has any pre-existing chronic mental illness, that will also decrease, as well as the symptoms of TB.
Thanks for listening.